give everybody just a second. Looks like we have everyone logging in right now. But I do want to go ahead and welcome everyone. My name is Ginger. I'm the Executive Director of the Connectionology Seminars of America. And I just want to thank you so much for all of your continued support. We are thrilled to be offering this part 2 webinar for you. So you'll have a greater chance to ask a lot of your questions, and then we'll be able to finish covering the information that we had from part 1. But before we begin, I'd love to go ahead and introduce our incredible sponsors for today. And let me just find Keith real quick from Global Litigation Consultants. He'll be joining us in just a minute. And then I'm going to bring in Paul from Strategic Relationships. He should be here in just a minute as well. How are you doing today, Keith?
I'm doing well. Thanks for having us.
Thanks for being here. If you don't mind, tell us a little bit about what you guys do at Global Litigation Consultants.
Yeah, of course. I am a business development consultant, and we assist in the litigation lifespan, everything from pre-suit services. So we have a team of nurses that does merit evaluations, case analysis, settlement demand prep, various different customizable projects as well. And so that's all pre-suit. So we can take a look at your case, interpret the medical records, and then on the post-litigation side of things, we can help with lien resolution, government benefit compliance. If your client needs a special needs trust, anything along those lines, we're happy to help. And so, if you have a complex situation and you want to just reach out and bounce it off of us, we're happy to discuss, free of charge, see if we can come up with a solution for you.
Fantastic. Well, we are absolutely honored to have you with us today. And I'll make sure that everybody gets your contact information at the end of this webinar so that way they can reach out. But I know you guys are doing so much good work with clients all over the country. So thank you for everything you do. And then thank you for being such a great supporter of ours.
Thanks for having us.
Absolutely. And now it's my pleasure to introduce Paul, who's the owner of Strategic Relationships. He has been a great friend of ours for many years now. And Paul, we are so happy to have you. Thanks for being here.
Thank you. It's great to be here.
Yeah. If you don't mind, tell us a little bit about what you guys do and how you can help our attendees watching today.
Sure. So at Strategic, we have a very, very simple message to trial lawyers. It's turn your jurors against your defendants with your defendant's own ex-employees. So for almost 20 years, we've been identifying the kind of ex-employees that your defendant was hoping you wouldn't find and turning them into insider witnesses or whistleblowers against those defendants. Let me bring up something very quickly, and that's we also, in the matter of your defense experts, I was at Lanier 1.0 5 years ago, and there was a defense expert that Mark said had been used numerous times. No one had ever bothered to check his credentials until someone finally did, and they found that so much of it was fictitious. So if you could find an ex-employee, if you go into their background, or you find an ex-employee that would say, he told me that he would never find for the plaintiff's side, something like that, we can find out that defense expert is actually pretty much bought out by the other side. We can help you in that way as well.
Fantastic. Well, Paul, thank you so much for letting everybody know. And I'm going to make sure that everybody can reach out and contact you after this webinar. And I know we have a great announcement later on that you guys are giving away one of our attendees a $100 Fleming's Prime Steakhouse gift certificate, which is incredible. Thank you so much for doing that.
Thank you.
I can't wait to see who the winner is going to be. Thanks, Paul.
Thank you.
And now I'd like to go ahead and let you guys know that for this webinar, if you have any questions, down at the bottom of your screen, there's a Q&A box. If you could write all your questions in there, that would be wonderful. And also I want to let you know that for several of you who live in like Florida, Georgia, Tennessee, New York, New Jersey, and Arizona, you are going to be able to get at least up to 1.5 CLE credit for just watching this webinar. So it's a wonderful thank you to all of you, and we are just so thrilled to have you. You can also watch more of our webinars. Just stay tuned to connectionology.com. But I'd like to go ahead and get started with today and introduce Hali, who is our wonderful moderator. She was with us on the first webinar, and you've seen her throughout other webinars that we've done. She is a great trial lawyer who works with John Romano out of the Romano Law Group down in West Palm Beach. She handles a variety of wrongful death and personal injury matters, but concentrating her practice on traumatic brain injury cases, as well as structural collapse cases. She's earned her Juris Doctorate degree from Florida Coastal School of Law in Jacksonville, Florida, and her Bachelor of Business Administration from Stetson University in DeLand, Florida. In addition to practicing law, Hali also has a wonderful passion for supporting women in the legal profession. She is the founder and the co-chair of the National Trial Lawyers Women's Leadership Forum. She's also committee chair for the Palm Beach County chapter of the Florida Association for Women's Lawyers. And she's on the board of the Florida Justice Association's Women's Caucus. And she's also a member of the Palm Beach County Justice Association's Women's Caucus as well. And they do a lot of great work down there. And then one other tip about Hali is that she also sits on the executive board of the National Trial Lawyers Top 40 Under 40. So Hali, you are extremely impressive, and we are so lucky to have you. And I cannot wait to see what everyone's going to talk about today during the webinar. So thank you very much. And now I leave it up to you.
Thanks so much, Ginger, and thanks for that introduction. Welcome everybody to part two. Today we're going to be talking about neuroimaging and how to get the best evidence for your TBI case. We had a wonderful part one where we had so many questions and interactions. We weren't able to get through everything, so we're bringing you back today for part two of this incredible and largely informative webinar. Today, our esteemed panel is going to continue the discussion about an array of neuroimaging tools available to help prove traumatic brain injuries. As Ginger mentioned, we're going to take questions as the webinar progresses today. So please use your question and answer box at the bottom of your screen, and I'll help to facilitate those questions and get them answered for you this afternoon. And for those of you who weren't with us for part one, I want to quickly introduce to you our esteemed panel and get right into today's discussion. First, we have Hugo Chanez. He is a partner at Mitchell Sanchez in New Orleans, Louisiana. He has practiced law all over the world. Currently, he focuses his national practice prosecuting traumatic brain injury cases. He is also a fellow of the American Board of Trial Advocates program at the Harvard Law School and part of the National Trial Lawyers Top 40 Under 40. Also with us this afternoon, we have Kyle Kinberger. Kyle is the National Sales Manager for HMR, which is an industry leader in medical funding. He has helped hundreds of attorneys get necessary funds for their clients' medical care, and he currently oversees the daily operation of business done in the 39 states where HMR currently operates. And lastly, but certainly not least, we have Dr. Travis Snyder with us today. He is a neuroradiologist specialist with SimonMed Imaging in Las Vegas, Nevada. And I'm going to pass it to Kyle now to further introduce Dr. Snyder and to get us started today.
Yeah, you got it. Thanks. I think it was great if for everybody who couldn't be with us this last time. You know, we touched on what really seemed like the tip of the iceberg with Hugo and Dr. Snyder as far as the advanced neuroimaging and what's available out there, and how each one of these options, whether it's SWI or functional MRI or DTI, you know, kind of plays into the case. And so I think it was a good problem to have last time when we had so many questions that we couldn't kind of get through all the material. But I think where we want to pick up today is to really dive a little bit deeper into more of diffuse tensor imaging and some of the aspects that go along with it. So Hugo, with that, I'm going to turn it over to you so we can open up the discussion with Dr. Snyder.
Thank you, Kyle. Yeah, where we left off last week was DTI. DTI is probably the most spectacular type of evidence you can use at trial. Juries love it, judges love it, defense lawyers hate it. So like we've always said, whenever you use DTI, it's fantastic for your case, but you're going to be challenged. But I think Dr. Snyder is going to show us in the next few slides why it's such a powerful tool to use for trial, for proving your damages. And when you can link it all together, it really does make your case bulletproof. Just be aware that it's such good evidence you're in for a fight. And we're going to talk a little bit about how we prepare for those fights and how we overcome those fights to be able to get this evidence into court in front of a jury. So Dr. Snyder, why don't you take on?
Great. Well, thanks so much. And thanks to Hugo and Kyle, Ginger and Haley. And yeah, we had, as you were saying, we had so much fun last time. We went way over time. So it was really, yeah, last time we had a great discussion and really enjoyed it. Lots of great questions. And so we're going to finish up today. So I'll share my screen here. And okay, so hopefully everyone can see this. Thumbs up. Okay, good. Okay, so this is our part 2. As we said, part 1 went over time. And these are everyone that we just discussed, and these are all my affiliations. So last time we discussed, and if anyone on this call does not have the prior PowerPoint, we'd be happy to share it with you all from part 1. But last time we talked about the optimal TBI protocol. We spent actually quite a lot of time talking about SWI and thin section triplane imaging, a little bit about DTI, and we talked a lot about volumetrics and the benefit of those and to be optimal to detecting traumatic brain injury. We talked about imaging findings which were highly specific for head trauma. So we talked about diffuse axonal injury. We talked about contusions and hemorrhages. And then also we talked about not just diffuse axonal imaging, which you see on SWI, but we talked about the locations of diffuse axonal injury, which are related to poor prognosis in the medical imaging literature. And so we showed examples in the midbrain, of the corpus callosum, and the pons, and some of those areas. And also we talked about burden of overall hemorrhagic diffuse axonal injury. So it's not just enough for the neuroradiologist to say there is hemorrhagic diffuse axonal injury, but to break it down and say, what's the burden? Where's the locations? Are any of those regions associated with poor prognosis? And then also to relate any related findings. For example, if you have hemorrhage in the left temporal lobe in one area, but then the whole temporal lobe cortical volume is decreased on the volumetrics, then you could say that there is, of course, there's damage to the temporal lobe, but it's actually larger than the areas of diffuse axonal injury. We talked about how diffuse axonal injury was, in fact, the tip of the iceberg, where there's many other findings that you see underneath that. So then we went through a little bit fast last time, some of the findings possibly related to head trauma. We talked about a Chiari malformation, low-lying cerebellar tonsils, whiplash type injury a little bit. We talked about cavum septum pellucidum, and a few other things as well. So, and then we talked about all the atrophy here that we saw, the global atrophy, ventricular atrophy, hippocampal atrophy is commonly affected in head trauma, and cortical atrophy. So that's where we left off. So now we're going to begin or continue our prior with these white matter shearing, and then we'll get into DTI, which is really, I think, perhaps the most exciting part of this. But white matter shearing is something that is a big focus of research, and it's actually these types of non-hemorrhagic shearing injuries are fairly common in head trauma, and it's I think they're oftentimes a very important or sometimes critical part of the case. So I think this was we left off before this slide last time, and we're talking about when to image, and we had a lot of questions about that, great questions about the trade-offs. And so we said you want to image early for the reasons that you want to detect because hemorrhagic shearing injuries and non-hemorrhagic shearing injuries will both about 50 to 80% will resolve on the follow-up MRIs. So that's the reason to image early. And also contusions will get smaller. And I think I showed the literature in the prior presentation, citing all those references if they're needed of what articles actually discovered that or found that or best represented that imaging finding. So that's the reason to image early, because the contusions and the hemorrhagic diffuse axonal injury and the non-hemorrhagic will improve on follow. So you want to detect them early. And then, why would we image late? And so that the reason to image when you want to image later is because of volume loss. So the volume loss will begin immediately. And so if you image early, you'll have a baseline for the volumes. And we use NeuroQuant. There's other programs out there as well that look at like 48 regions of the brain with volumetrics and compare it to a normal database. And so if you image it immediately and then 6 months later, volumes in certain areas decrease, then those would be consistent with the history of head trauma. And it peaks about 3 to 6 months. So ideally you would get an MRI very close to the trauma, and then you would get an MRI maybe 6 months from the trauma. And sometimes we have, last time I showed some graphs where we plotted data points on patients that sometimes even had a pre-trauma MRI, which is, if you have that, that's very helpful. Talked about tracing the lateral ventricles, how lateral ventricle size is indicative of poor prognosis, because it means there's a diffuse brain injury if the ventricles get bigger, which are fluid-filled spaces in the center of the brain. And we talked, and CT is also helpful, as we discussed. All right, so let's talk about white matter foci. So this is a very interesting topic, and we're doing research on this in our group here. And so these white matter, on this image on the right here, you see these little white matter dots. You can call them white matter dots. You can call them shearing injuries in the right setting. You can call them white matter hyperintensities, or just focal areas of increased T2/flare weighted signal. Those are all synonymous terms. So one of the issues with these is that these are common in aging. So as people get over 50 especially, they start to have these little white dots come up. You can also see increased white matter hyperintensities in patients with hypertension, a long-standing hypertension, not kind of, I had 10 doctor's visits and one of them had a little bit of high blood pressure. And these are people that are on medication for it for a long time, especially malignant hypertension. Diabetes, and not pre-diabetes, but more people like chronic diabetics. Smoking, and not young people that smoke, people that have been smoking 30 years. You can see them in unusual conditions like Lyme's disease. You can see them in migrainous angiopathy. Actually, I was working on a case this weekend where that was actually a focus of the whole case, was on the migrainous angiopathy. Some people were saying that these white matter hypertensives were caused by migrainous angiopathy. But these are typically in the deep and periventricular white matter, not the subcortical white matter. So you can distinguish between these conditions. Multiple sclerosis, younger females, you'll see a lot of white matter hyperintensities in those patients, but they tend to be periventricular. They tend to be perpendicular to the corpus callosum and involve the corpus callosum. Sleep apnea, not as well described. I mean, no radiologist is going to say, these white matter findings are consistent with sleep apnea. That's just not something that it's not very common, but there is some articles that say there may be some increased white matter hypertensities in patients with sleep apnea. In postpartum, there are some articles that discuss how postpartum females, for unknown reasons, will sometimes get a little more white matter hyperintensities. And then other infectious inflammatory causes. But certainly, they can occur in head trauma. And it is actually, it's not my opinion, it's a medical fact that white matter hyperintensities can occur in head trauma. There's people that say they cannot, and that opinion is way outside the medical mainstream. If someone says they have to have hemorrhages on the brain or else they're not injured, that's just that's so far outside the mainstream of medical opinion. And so here's an example of a case where this is very close to the cortex here at the subcortical junction in a young patient who had head trauma. And so this would be consistent with that history.
Snyder.
Yes.
Can I jump in for 1 second? Because something really important.
Please.
Going back to your slide, the hypertension, the smoking, for anybody who does TBI work, if you get a smart defense lawyer that knows about TBIs, be prepared. They are going to look in your client's medical records. They want 10 years of medical records. They're going to look for smoking. They're going to look for hypertension. They're going to look for all these things to try to say that those findings on the imaging are related to something else. So that is why you need to be well-versed in your client's records and work with a neuroradiologist that understands your client's records, because all the arguments, I've seen them in all the cases that we and Dr. Snyder have had together.
Yeah, those are very good points. And so the hypertension and diabetes, these white matter hyperintensities also, they tend to involve, the white matter has 3 anatomic regions. There's the periventricular white matter, which is the deep white matter close to the ventricles. That would be kind of this region right here. And then there's deep white matter, which would probably be kind of in this region, like this one would be deep white matter, maybe this one would be deep white matter. And there's subcortical, which is right here, and right here. So those are the 3 anatomic regions, and hypertension and diabetes affects all 3 regions. So if you see someone that has, like this patient here, I mean, you have them in all 3 regions. So in that case, you're really tough to say that that it could be trauma. But if there's a case where it's only subcortical, even if they have some of these conditions, you might be able to. I mean, it depends on the case, but the hypertension, diabetes will involve all three. Whereas trauma typically involves subcortical. It can be deep, it can be paraventricular, especially in more severe traumas, but mostly it's subcortical. So differentiating that anatomy, I think, is quite important. So here's some examples of the literature on white matter shearing. This was a boxer published by Dr. Orson in Journal of Neurotrauma, showing some of these subcortical foci, which should be consistent with the history of trauma. Here's a military article showing white matter hyperintensity right here, and there's the contusion. So they had a contusion and they had a white matter hyperintensity. What was interesting about this case is in a 3-month follow, they did a 3-month follow-up, and this white dot here, the shearing injury, disappeared. And so if you look at the article, you can see it's there and then it vanishes, and that's showing how these white matter hyperintensities will decrease over time, which is why it's important to image early if you can. But the ones that stay there are going to be there permanently, and it's permanent damage. And just because the white matter hyperintensity goes away doesn't mean the brain heals. We should be clear about that. The damage is done, and the brain does not heal itself. It's not like your wrist or your foot where you have a cut and it heals. The brain does not regenerate. So any kind of brain damage that you get from anything that we've discussed is permanent. So here's some other examples of non-hemorrhagic shearing. So this is an article, and if someone ever says that you can't have, if without hemorrhage there's no brain injury, I mean, you could just show them this article. I mean, the title of the article is Non-Hemorrhagic Brain Lesions and Diffuse Axonal Injury. I mean, it can't be any clearer than that. And so this is showing a flare-weighted signal showing the injury to the splenium here, which is quite a prominent injury. This is not a white matter hyperintensity. This is a pretty big area of shearing. And this is the SWI. And as we were discussing last time, SWI is the best imaging for trauma because when you see those hemorrhages, it's almost 100% trauma in the right location, in the right locations, in the right morphology. And you can see it's negative for hemorrhage. So there's no hemorrhage there, but there's the large injury to the splenium. Poor prognostic sign. Corpus callosum is a poor prognostic sign to have that injury. Here's another example from the literature from Reed et al. And this is showing a white matter hyperintensity. This is really a classic non-hemorrhagic shearing picture right here. Look how close it is to the cortex. It's very close. It's white matter hyperintensity. There's no hemorrhage with it, but it's a shearing injury. And the most common location for these non-hemorrhagic lesions was cortical and subcortical. So if it involves the cortex or in the subcortical region. And the subcortical is what we really typically see. So, all right, so one of the questions that comes up quite a bit, as Hugo was alluding to, is what is the prevalence of white matter lesions in young patients, young people? And the literature is a little bit varied, but it's most articles, and I have a collection of all these articles that have looked at this. As I mentioned, our group's doing research on this. We found that head trauma patients have, with white matter hyperintensities, have worse outcomes. And that's also been described in other literature, such as the article by Tate, T-A-T-E. And there's other articles too, that they actually have worse outcomes. And most articles indicate that white matter hyperintensities in young patients are actually unusual if they're healthy people, which most young people are healthy. So this is kind of the key question that comes up in a lot of these cases. When is a white matter hyperintensity in a young or middle-aged patient likely related to trauma? Now in an older patient, the way that I sometimes will dictate these studies is, so say you have a patient like this, who has a head trauma, some of these could be traumatic, but they're just hidden like a needle in a haystack. There's so much white matter disease from aging that that some of these subcortical foci could be traumatic, but you can't say it more likely than not based on the imaging alone. But there are clinicians who can examine the patients, and the patients are doing very bad. They had a pretty significant trauma, and I've seen clinicians say that that they think there's diffuse axonal injury based on the history, and that the imaging findings suggested And then, I'll support them and say that these subcortical foci have been described in head trauma. These are right there. Here are some literature examples. And but based on the imaging, it's tough. It's really tough to differentiate that from chronic small vessel disease. But anyway, but in younger patients, the age is a big thing. So when is it likely related to a trauma based on imaging? And so then the age, and then of course the history of trauma and the clinical suspicion. I mean, if there was just a very a minor trauma or something, then, or it's not really clear if there was a trauma, then it might be tougher. Clinical suspicion, patient's not doing well, has a lot of symptoms, and then especially this additional positive traumatic findings on the scan. So if there's an area that's kind of, you're not sure, it's kind of questionable, but there's a contusion, there's hemorrhage, that might sway the neuroradiologic opinion that it's more likely traumatic based on other findings. If there's volume loss in that region, if there's abnormal diffuse axonal diffuser tensor imaging in that same region, sometimes that will play a role depending on the case. Exclusion of other risk factors. So we have patients fill out questionnaires and we ask them about some of this stuff. And if there's no other risk factors, or sometimes if I'm an expert on a case and I'm able to review some limited medical records, I typically don't review voluminous medical records. That's not really, at least in a standard way. And you can exclude other risk factors. And then location is probably the most important. Subcortical location, subcortical predominance of lesions, white matter hypertensives that are advanced for a patient's age. And then size, morphology, and number also will play a role. All right, so are there any questions or comments regarding white matter hyperintensity / shearing injuries in head trauma patients?
We have one question so far from our viewers, and that is, are there any British or US publications that can be referenced in regard to the white matter changes following shear type injuries?
Yes, so I have cited some of these here. So Red et al., that's a good one. And then Chung, that's a good one. Then this one by Orson and this one by Bradstack. This is a military article. So those are articles that talk about it. There's other articles. There are articles there is a British article, maybe that was what the question was referring to, which talks about, it was published in the British Journal of Medicine, I believe, but it was a review article on the incidence of white matter hyperintensities and other findings, other findings on imaging. And that article found a very low rate of white matter hypertensities. Looked at 20,000 patients, so it was a pretty big article, pretty big series. But there's other articles that talk about the rate. There's a great one by I'm blanking on the name of it, but that talks about there's 243 patients that talked about the rate of white matter hypertensities.
We have two additional questions. The first being, what is the youngest age that a person can undergo a DTI?
As long as they can, I mean, we've done it at our centers without sedation, and I think the youngest we've done it is 4 years old, but we, if a physician is willing to write for a script for a sedative, we could try it on patients. Sometimes the parents come in and they hold the child's leg in the scanner, and they kind of hold their leg while they're in the tube. Some kids are just too scared and they start, freaking out or moving, and then we can't do it. But there's really not really an age limit, but it's kids under 5 or 6. It is. We never know if we're going to get a good scan.
Could you give more detail about why subsequent DTIs could show disappearance of prior positive DTI findings and yet brain injury is permanent?
Well, that's a complex question. So DTI. So I didn't get into this in this particular talk, but diffuser tensor imaging can be different over time. So if you image them acutely, like hyperacutely, like at the same time as a trauma, you can see FA values which are different, and if you image them later, then they will either improve or worsen depending on the time frame. And the literature actually is not that clear. There's sort of some discrepancies in the literature looking at the time frame of DTI, how the values will change. So FA values, we'll talk about that, can be increased or decreased. And there's lots of most literature is on decreased FA values, but there is literature on elevated FA values too. And so the thought is that it could relate to a chronic inflammatory response where the FA values can change over time. But what the questioner is describing is a little bit unusual. The vast majority of DTI cases that I read are, when you image them over time, most of the time we get the patients that typically come in, not immediately because we're an outpatient center, but they come in 3 months or 2 months or 4 months. And we see the diffusion potential imaging values very static overall. So they don't really change. And that relates to the permanent damage to the fiber tracts. It's not the case that tensor tracts can heal. We know the brain cannot heal itself for intents and purposes. So I've never heard of someone saying that because in the unlikely event that a future DTI exam is different than a prior one, that it's due to healing changes. I just don't think that's really ever been described.
And one additional question, Dr. Snyder, this is from an attendee who says, I just signed up a 16-year-old with loss of consciousness and moderate tractor trailer collision. I will try to send her for further imaging, but she also plays soccer. Can a doctor say from imaging or a clinical exam that findings are caused by the wreck and not sports?
Well, that would be probably if it was that would be mostly on the clinical, not the imaging. So if it was say a patient had a skull fracture, playing football, and then they were in a fender bender, then, the imaging findings are more likely to be from the sport injury. So it just depends. But minor sport injury, without any significant reported head trauma is really not going to cause imaging findings. So it would depend on the clinical history. And most of the time, it's fairly clear what the most significant, that's one of the questions we get, because sometimes you can sort of date the trauma with the volumetrics, but a lot of this stuff, you can't really date trauma on imaging. But lots of times when you review the medical records or you look at some of the things in the case, that it's very clear that this was the worst head trauma of the patient's life is the one in question. And if that's the case, then it's not really an issue that the patient had trauma. Now, one of the questions I had recently, a patient had a severe head trauma when they were younger, and then they had a kind of a moderate head trauma when they were older, which was a focus of the litigation. And the question was, is it worth to get imaging? And I as much as we like to image people, it might be worth it. It might add something, but in that case, because whatever we see on the imaging is going to be very tough to say it's not from the more severe earlier head trauma. So in those cases, it might not even be worth to image those people because, what are we going to say? There's evidence of head trauma, but that's already known, So, that's something that comes up from time to time.
Doc, one of the things that you touched on was imaging early, if possible. And so, Hugo, I have a question that maybe kind of dovetails into that for you. And that's, we get a lot of cases these days where they present to an ER, they have a CT or an MRI and it's normal. But then, there's a persistent symptoms or whatnot like that. And then I find that it's a lot of attorneys are having trouble getting the appropriate imaging orders, whether it's DTI or if a neurologist or a physical medicine doc, are they going to know about SWI and that might be one of the better tools for trauma? I'm curious how you navigate that from an intake standpoint at your practice.
No, that's a good point because there are standards of practice for each specialty. Traditionally, it's always been thought that you would follow the patient for conservative treatment for 90 days And then if the symptoms didn't resolve, you would get your referral to your neurologist. And then your neurologist would probably do conservative treatment for 30 more days. And then they would start ordering the imaging testing, which now puts you at least 120 days out. I think a lot of the research and the thought process in that is changing. There are a good series of articles nowadays that say that the quicker you can get cognitive rehab, the better outcome for the patient. And we're able to get them to a neurologist a lot faster, but you do need to work with your neurologist to say, this is a potential head injury, be aware it's a head trauma, so that they can order the imaging. And listen, if it's a case that's important enough to you, I've done this before. I've had Dr. Snyder get on a phone call with a neurologist and say, Dr. Snyder, what exactly do you need them to order for you so that you can get the right imaging done? We did that recently in a case. Set up the phone call.
Yep.
Because the neurologist said, okay, I'll order a regular MRI. I'm like, well, that may not be what we need. So I called Dr. Snyder, set up a phone call between them, and I got the order, and the order was then sent over to SimonMed, and the client will get the scan that's appropriate with all the protocols Dr. Snyder needs, that will then go back to the neurologist, because again, remember, the imaging is just a part of the puzzle. The neurologist makes the clinical diagnosis. But you have to work on it on a communication basis, knowing that if you're going to be working with a neuroradiologist, they need to be involved early on in the process.
Got it.
Well, Kyle, to piggyback on your a good point there. Yeah, and even if you image the patient, significantly after the trauma, it doesn't mean that you're not gonna see stuff. I mean, your best chance is to see early, but a lot of things. I mean, I've read cases 10 years after the trauma, and it was a significant trauma, and there's all these findings there because they had a poor quality MRI before, and we see it now, and we can certainly relate that to the trauma because there's no other traumas in their life, and there's hemorrhages, or there's shearing injuries, there's abnormal, all kinds of things. Because a lot of this damage is permanent. So it doesn't mean that if you don't image early, it's still worth it to image in. Another thing that's helpful is to work. Thankfully work with a lot of neurologists that specialize in head trauma, and they know all this stuff very well, and I have their cell phones. I can text them. You can talk about something that they're looking for that's a little atypical. And so when you're working with those people that really understand, the literature, it's pretty helpful. And a lot of centers also have these protocols all standardized. So even if they don't order advanced TBI or DTI, at our centers we'll do it automatically because we know that's what's the best for the patient. A lot of centers are like that too. So even if they don't, it's not like someone ordering these exams has to put in, add neural quant, add SWI, add DTI. That's all done. It's all part of our standard protocol. So that eliminates a lot of problems.
Got it. Thank you.
All right, should we move on to DTI?
Go for it.
All right. So let's roll. So DTI I like DTI a lot, as we were talking about. It's a very exciting technology, and it's very sensitive for traumatic brain injury. So how DTI works? It's an MRI sequence. It can only be done through MRI, and it measures how water flows along axons. And axons are very, very tiny. They're thousands of times less thick as a human hair. And there's millions and millions or billions of them throughout the brain. And axons tend to be bundled, almost like telephone wires that are bundled together. So all these axons go all throughout the brain, and they're connected to fiber tracks. And you can use DTI to look at how water moves along those big bundles of fiber tracks. And it's sort of one analogy would be a glass of water. If you look at how water is moving in a glass of water, all the molecules move randomly. So they're kind of bouncing all around. But if you put a straw in the water molecules will move preferentially along the straw. So they'll move up and down along the straw. And that's what DTI is measuring. It's measuring how water is moving in the straw, these telephone wires of the brain. And so what we can do is give a numerical value to how the water is moving. It's called an FA value, a fractional anisotropy. So it gives a numerical value to how, basically to the health of the axon. And low values are indicative of axonal injury. and even in some cases high values as well, but especially low values are most commonly described in the literature. And DTI is sensitive for head trauma. It's probably the most sensitive imaging modality that there is. Sensitive means it will pick it up. One of the problems with DTI is sort of the same with white matter hyperintensities, is that if you have an older patient who has hypertension, who has diabetes, who is a smoker, then you can say it's abnormal, that the DTI is abnormal, but you're a little stuck sometimes to say it's from the trauma or whether it's from some other condition the patient has. So it's not as specific for head trauma. But anyway, so that's DTI, and this is kind of what it looks like. And so there's three ways to interpret DTI. The first is just the axial colored maps, which is this. So this is anterior, right, left, and posterior. This is the corpus callosum, and these colors are arbitrary. They don't mean anything. They're based on how the computer assigns these values, and they're looking at things. But and so you can sort. So a lot of times you have a contusion here, and you look in the axiom, you'll see that of course the contusion is going to have no fiber tracts. But then sometimes what you'll see, and we had a case recently of this, where the fiber tracts are disrupted beyond the contusion, just like perfusion. So perfusion is another imaging modality we talked about last time, looking at blood flow. So similar to that, the diffuser tensor imaging can see that there's disruption of the fiber tracts beyond the contusion. So that's one way to look at it. The other way is to get those FA values that we were discussing. And this is how we do it at SimonMed, and a lot of other places do this too, where the tech will trace this and it tells the computer to calculate the values from this region. This is the corpus callosum in a side view. This is the front, or the genu in the body, and then the splenium in the back. And so you get values for each of these regions, and these are the values in this particular case. And we have a good understanding of what values are abnormal and normal. It is based on age, so you have to consider the patient's age, because as you age, the values will go down. And then you can describe if they're normal or abnormal. And you can measure other regions in the corpus callosum too, like Mindset does, which we'll get to. But a lot of there's many articles that focus on the corpus callosum because it's the largest fiber tract in the brain. It's the only fiber tract connecting the right and left hemispheres. So it's very easy to do. There's many articles on it. It's probably the fiber tract in the brain that has the most literature on it. So that's why that we do this. And the corpus callosum is a structure that's commonly injured in head trauma because it's the only fiber tract connecting the right and left hemisphere. When those hemispheres are jostled, the thing that connects them can be damaged. So that makes sense sort of intuitively. So the third way to look at DTI is through these 3D reconstructions of the fiber tracts. And when I'm interpreting diffuser tensor imaging, I use kind of all three methods. So there's the axial, and then the FA, and then the 3D. And the 3D takes this color image of the axials and turns it into a three-dimensional image. So you get these beautiful images which you can put in the brain, superimpose. So this is the corpus callosum. These are all the fiber tracts coming off the corpus callosum. This is a normal case. This is kind of a normal case showing these three-dimensional fiber tracts. And often the three-dimensional DTI will correlate with the decreased FA values. So if you have FA values which are increased in the front of the corpus callosum, you'll see that these fibers are trimmed or there's a gap in those fiber tracts. So it adds a little more, that when things match, it adds more credibility and science and accuracy to the interpretation. And this is a case of multiple sclerosis, not head trauma case, but multiple sclerosis is one of some of the worst fiber tracts that I've seen have been in multiple sclerosis patients. And I've seen pretty bad in head trauma, but multiple sclerosis is a disease where the antibodies your own antibodies attack the white matter fiber tracts. So the disease is focused right at what the DTI measures. So there's many articles on multiple sclerosis talking about DTI. And this is a case where, if you compare this to the normal, slightly different technique in these two images, but you can see how torn up the fiber tracts are from MS. So certainly it's a valid technique. So now, any questions on the technique of DTI before we show some cases?
Can the reading of a DTI image does it always have to be human or radiologist read, or can it be read by computer models, analytics, AI?
Well, yes, computer programs and AI and things like that are used sometimes to automatically calculate FA values. I mean, we have our techs do this, but there are computer programs that work very nicely to do this. I mean, all it is fairly mindless. You just trace a circle. So, I mean, computer programs can do that as well. But the interpretation of it, I don't think a computer program, at this point anyway, could say that this is normal or abnormal. I mean, you can tell it, you can give a threshold and then it will say that. But I mean, I think interpreting DTI in context of the case in terms of other imaging findings is quite important. So I think it ultimately has to be a neuroradiologist or a neurologist, or clinicians interpret these as well. They incorporate it with the clinical value. Neuroscientists can look at this, but for a computer program to say abnormal or normal based on this without looking at the whole picture, I don't think we're there yet.
The other question we have is for Hugo, wondering if, Hugo, you could provide a response brief or some sort of citations nationwide showing where DTI was admitted or allowed and why, given that DTI always brings a Daubert challenge.
Yeah, actually I can. And there's a series of articles out there that have looked at the use of DTI in the courtroom setting. I'll try to pull them for you. That looked at, I think one's called DTI 10 years later. And it gives a series of citations to all the courts that have allowed DTI to be accepted in as evidence.
Maybe you're talking about this one, Hugo? I don't know.
There you go.
Yeah. So that's, yeah, we'll get, but that's a great article which talks about it. All right, any other questions?
Right now.
Nope, we're good.
Find where I was here. Okay, so now we'll show some cases. So here's a case, and we can start out with this and go backwards. But this is SWI. This is a three-dimensional reconstruction. Remember last time we were saying that that's helpful if the imaging center has that, because you can do things like this with it. This is a sagittal image showing a frontal hemorrhagic diffuse axonal injury. Hugo, I think this may have been the case, a case that you and I had together, actually, if I remember correctly.
That's it.
So this is a hemorrhage in the frontal lobe here, and then there's a shearing injury very near the cortex as well. So there's two injuries to the frontal regions in this patient. And this is a side view showing kind of where you are. This is the corpus callosum, and showing where these images are in the brain, kind of in the frontal region. And then very interestingly, the diffuser tensor imaging showed this gap here, which on both sides, which matched where these hemorrhages and the shearing injury was. And so it's not unusual to see these DTI matching the conventional imaging. I think if you have that, it's great from a scientific perspective, because it nicely illustrates, it shows the value and the validity of diffuser tensor imaging when you have a case like this.
And Dr. Snyder, let me jump in there for a second, because that's really important. So for those of us who try cases all the time, this is where the courtroom magic happens, because we're going to take a slide from Dr. Snyder and say we have an impact, and we layer it. We have shearing, we have we have DTI, we have 3D imaging, and you put layer upon layer upon layer. And at some point, you have so many layers of your brain injury that it is almost an insurmountable amount of evidence you can build. And when you put it together with the DTI imaging, that colorful picture right there, juries understand the concept. They see it, and every single time when the defense attacks it, it could be multiple sclerosis, it could be smoking, it could be alcohol, it could be this. There's too many coincidences in place. You want to build your case in layers, and you want to be able to get everything to match up. Your neuropsych testing should match up, and your injury should match up. That is how you build the case that they cannot defeat.
And speaking of layers, this case also had spectroscopy. So this is a spectroscopy grid. And I didn't get much into this. I could do another talk on that if you want. But this is a grid that's laid over the brain. This is the anterior, and this is the posterior, and this is right and left. And it's placed above the ventricles. And it works by measuring micrometabolites in these little voxels. Each one of these is called a voxel, these little squares. And so the front of this patient has decreased, one of these metabolites is decreased relative to the others, which has been described in traumatic brain injury. So in this case, the anterior spectroscopy also matched the DTI, which matched the non-hemorrhagic shearing, which matched the hemorrhagic shearing. So this is and of course, not all cases are like this. I'm showing the best one to you all, but you know, that's kind of fun when it all comes together like that. So here's another case, and this is a case of a very unfortunate 6-year-old boy. And here's a side image, sagittal image, showing this area of scarring or contusion. He had bilateral frontal contusion. So I think this was the right side. So we're off the midline here. So this is a side view off the midline. And this is the opposite side. So this is on the other side of the head, way off the midline. You see the gap there. So that was where the patient had bilateral frontal contusions in this particular case. And then look at the 3-dimensional DTI. And you can clearly see that it matches quite nicely, unfortunately for the kid, but all the contusions are on here, and it even goes back a little farther than the contusions. And so it involves all this region. So it really shows how there's not a regional frontal bilateral injury, it's a global frontal bilateral brain injury. And you know, as Hugo was saying, you can take these and you can spin these around so they can rotate, you can turn them upside down, and you can superimpose the brain on them and to show them in different demonstrative ways or illustrative ways to illustrate the pathology. So this is the same case, but it's a coronal view. So it kind of looks, you can see it better here. This is the left frontal contusion, a whole area of dead brain. This is the right frontal contusion, a whole area of dead brain, and the matching DTI. So you can show it in different ways to illustrate it. Here's another case. This is a terrible trauma case. This is a sagittal T2 image, and it shows that the whole frontal lobe is completely smashed, or encephalomalacia gliosis there, which is cystic change and scarring. And there's a separate region back here in the back. And so the 3-dimensional DTI, again, correlates very nicely, showing how this is all destroyed up here. And then also the other area in the back, it shows it well there. And so this is that same case showing that abnormal 3-dimensional DTI superimposed on the brain structure. And then also this is a color map. So we showed that axial color image of the DTI, and we can turn it sideways to make it sagittal. And you can see how thin the corpus callosum is in the frontal region. And this is really where it should look like in the back. This whole thing, the whole front should be as thick as the back. So it shows there's a global injury to the corpus callosum in a devastating head trauma. And these are all ways to, to show it, and also in some cases to diagnose it. So here are some cautions on diffuser tension imaging, and I'll probably defer to Kyle and Hugo if they want to have some comments on this from maybe an attorney perspective. But these are some of the articles from Meltzer, and says that you can read it, but it says that the expert should offer alternative explanations, technical factors, and normal variations. Another paper by Wintermark says the data is confined to a research area for group comparisons. I'm highlighting group comparisons, a foreshadowing what we're going to talk about, and then it says that in routine clinical cases at the individual level, and then this RSNA statement, which was based on the Wintermark paper, says that there's insufficient supporting for. And so these are some of the contrary opinions to DTI, and there's many others and many other articles that talk about how great it is and how it's used and how it's used in clinical practice and all this. But just to be aware, this is the other side, and it's important to be aware of what they're saying and why they're saying it. And also there is some validation to some of this. I think we discussed last time that there's some imaging centers that they start doing DTI, and they may not have the right protocols. They may not have as many directions as is necessary. They may have, and they may not have any sort of experience interpreting it, because technique can play a role in the interpretation of DTI. So I think some of these criticisms that these people are talking about are actually quite valid in some circumstances. And so I'm not here to disagree with what they're saying, but I think there's an important caveat. And this is where some of the Daubert challenges come from, and some of those challenges that were being discussed.
Yeah, True. And go ahead, Kyle.
No, I was just going to say, I mean, that's a good point. I mean, you're talking about Dahlberg challenges and stuff like that. And I think a lot of times when, we're seeing cases with diffuse tensor imaging, they have somebody who's got what we call a positive DTI scan. And so, I think the first inclination of the attorney is, I've got a positive DTI scan, I've got a home run, it's game over. And is that the case? We've continued to talk about pieces of the puzzle here, but how big of a deal is a positive DTI scan when we're trying to litigate a brain injury case?
It's not the end all be all. I mean, sorry, Dr. Snyder, but a positive DTI imaging alone is not going to win your case. Again, it's a clinical diagnosis, and the way you avoid these Dahlberg challenges, you defeat them, is your neurologist or your physiatrist says, listen, yes, I looked at DTI. That's something else I use, but I looked neuropsych testing. I used my clinical judgment. I used my own experience. I talked to the family members. I looked at the ER records. It's not all based on DTI, because what's critical about this is that DTI is more sensitive than specific. And defense lawyers love to hone in on that phrase and say, it's sensitive, not specific. It could be 1,000 things. That's true. That doesn't mean it doesn't come into evidence. So put it into context. Defense lawyers love to use neuropsych testing. If you look at most neuropsych expert reports, they will begin with the same caveat. The neuropsych testing, it is more sensitive than specific. And in fact, there's a very well-known defense neuropsychiatrist, practices all over the country. Every single one of the reports says it. And he says, it is the appropriate role of the experienced clinician to determine whether it is related or unrelated to the index incident. You can do the same thing with DTI. You get a neuroradiologist, Dr. Snyder, who does it day in and day out. And again, it's a piece of the puzzle that goes to your neurologist, your physiatrist. It's not conclusive, it's part of it, and it goes into evidence as a part of your puzzle. If you're gonna win your case just on DTI, you are subject to a Dahlberg challenge and you might not be able to survive it.
Yeah. Well, some of the scans that come in that, again, we've seen with lawyers who are having clients, get a DTI scan, they're seeing these kind of comments come up in the reports, and it's, abnormal FA values or shearing and this and maybe not being able to quite make sense of, which one is the hammer and which one is just, something else. And so, I don't know if you focus in on something very specific when you're looking at the interpretation of the DTI scan.
Yeah, well, one thing that when I'm involved in cases, and I do plaintiff and defense work, so both sides is telling if the attorney's involved or the clinician if it's not a legal case, what is the strongest finding that this is the key, and I think that's incumbent on experts or consulting radiologists to tell people what the strongest part of the case and what is sort of as Hugo was saying, piece of the puzzle. What is more supporting, but it's not going to be the quarterback. It's going to be the, it's going to be a different part.
Got it.
All right, so let's go on here. So this is quite exciting here. So one of the more recent advances, and we just started doing this about maybe 6 months ago, or maybe even a year ago now at our centers, is using the GTI synchronized scanner to a normal database. And these are the articles that talk about it. And so how it works is a human phantom, which just means, they shouldn't say human phantom, it sounds like a ghost, but just anyone is scanned on one scanner and then is scanned on a different scanner. And if they're scanned on the scanner with a normal database and then they're scanned on some other scanner, because DTI techniques are different, it allows to synchronize those scanners, allows you to compare a patient to a normal database. So this is very exciting. I think in 10 years, probably from now, we'll be talking here, and every single patient that goes in to get an MRI will have a DTI exam with comparison to a robust normative database, and there'll be a lot of improvements in various various technique. And DTI is going to diagnose a lot of conditions, I think, in the future. So this is really, I think, the future of imaging, in my opinion. So what it does is it changes an individual scan to a group scan. So a patient was not scanned as an individual. They were scanned as part of a group of 300 people. So we go back to some of these objections. It says allows for group comparisons. And in this article too, RSNA, they talk about how group comparisons are valid. Meltzer, I think, talks about also how imaging has shown that group analyses have shown clear difference between DTI and controls. And so, by using this technique, you're in concordant with those criticisms, because you're scanning the patient as part of a group, and they've all three of those articles have said that group comparisons are valid or have demonstrated significant differences and other benefits. So that's the great future of DTI. And so the group that we use with this, in fact, I think it's one of the only groups out there, is called Mindset. And Mindset's partnered with SimonMed, and I've worked with them, and their Mindset is there's a bunch of PhD, there's people that are extremely well published, very scientific. They were part of Lovelace, which is a NIH funded research group. So, I mean, they're very rigorous, and they know DTI extremely well. Dr. Lewine has been one of the main pioneers there, and there's many other people they have on staff as well there. So that's the database that we use. I know there are some others that are out there. I'm not sure at this point they quite match up to the rigorous Mindset normal control. They have thousands of patients that were all scanned on the same scanner, which is very important. And they can match hundreds of patients, in some cases, within 10 years, same sex as the patient in question. And so this is what you get from them. And this was a patient who had 3 contusions, diffuse axonal injury, and they actually had life-saving neurosurgery. This was an unfortunate young girl. And so these are all the areas of they measure 48 fiber tracts using DTI, and then they get the FA values and you get Z-scores. And so when these values, this is the mean here, and if it goes above the mean, it's here, and if it goes below, then it's down here. And so basically, if it goes in, it's bad. And if it's above, it can still be abnormal too, but if it goes down, it means that's really bad. And so this one is almost 3 standard deviations below the mean. This one is 3 standard deviations, and that's one standard deviation is 66% or higher. 2 standard deviations is 95%, and then 3 standard deviations is almost 99% of normal people are not going to have it. So it's quite. And this particular patient, I mean, they're all. There's so many fiber tracts that are damaged, and it matched the conventional imaging. So, but there are fiber tracts that were damaged, which we did not really see findings on the conventional imaging. So the DTI value in this particular case showed this global brain injury, whereas we had multiple regional brain injuries. And the 3-dimensional fiber tracts did show that, because it says the splenium was the worst part, and that's the back. And so the splenium fiber tracts were damaged here on the 3-dimensional, so we could show that. So this is the case we showed before with the frontal contusions bilaterally and the 3-dimensional gaps here. And this is the Mindset report with the Z-scores. And look how terrible that is. I mean, it's just everything is almost 4 standard deviations below the mean. That's like 99.99% or something. So the patient has a severe injury, which was bigger than you might think just based on this. And this is based on 107 clients that were the same same age as this patient. So this is some literature showing how diffuser tensor imaging matches conventional findings. So sometimes you're asked, is this common for neuroradiologists to match DTI to conventional imaging? And I would say, yes. And here's the literature, which shows that the color maps were abnormal here, which matches the area of the frontal contusion. So, this is not just my opinion. This is something that is done by many other neuroradiologists. So here's a great case of this. I'll start with this image here. This is that SWI axial image, and shows these little black dots. Those are hemorrhagic diffuse axonal injury in the splenium of the corpus callosum. There's no differential diagnosis. The corpus callosum is commonly injured in head trauma. This was a young patient. So that shows where those dots were. And then this is not part of the image. I put this star in just to show where those injury was. Three-dimensional reconstruction of the fiber tracks matches nicely, shows those gaps, and the arrows are pointing at this thinning, which is right where that injury was. And then here's just a cartoon. It's not an image of the patient showing the anatomy here, and I put in that little star. And so then we got the mindset DTI, and look at the splenium of the corpus callosum. The rest of these areas, there's some areas here in middle cerebral peduncle, which is commonly injured in trauma actually, but other areas are not definitively abnormal, but the splenium, which is right where the injury was, matched the DTI, matched the three-dimensional fiber tract, and matched the hemorrhagic diffuse axonal injury. And injury to the corpus callosum is important. It's a poor prognostic sign. This is the article that talks about it. In head trauma patients that had injury to the corpus callosum, they did quite a bit worse than patients without. So all this stuff I think is important. This was a nice case where everything matched. So here's another case, different case, and this was a very recent case actually that I actually did like 2 days ago. Where it's showing the black dot in the right splenium. So the other case was the left splenium. This is the right splenium. There's this black dot there, hemorrhagic diffuse axonal injury, head trauma patient. And this is the axial imaging. And you can see here, it's a little subtle, but you know right where to look because you see that black dot. And you can see how the color kind of is a little different here than on this side. It's more red over here. And so there's some fiber tract disruption there in that right splenium. And it's fairly subtle, but we know it's there based on the hemorrhage. So then we look at the three-dimensional reconstructions of that patient. And this is different ways we can do it. You can do all kinds of stuff with these three-dimensional reconstructions. And you see the gap, just like we saw in the other cases, right in the same region of the splenium. So another nice case kind of tying everything together with a patient with poor prognosis from an injury. And this is the same case showing that injury, the gap, and then this is what a normal. So sometimes it helps to show this right next to it so you can see what a normal looks like. I think that's very helpful. I try to include a lot of normals when I'm creating PowerPoints or doing stuff because, I mean, a lot of people have never seen this before. And so to see a normal is helpful for them to understand that that is abnormal. And this is, this is different ways to illustrate damage to the corpus callosum. So you can do it in this way. You can add the red star there. You can show that anatomy. Red star, and that's the same case showing that. So there's different ways you can illustrate the science behind the injury. And then it's also helpful. Oh, sorry, go ahead.
Doc, can I ask you a question? When you talked earlier about mindset and how it plays into the scans and obviously measuring up to other patients of same age, et cetera. Is that something that comes standard with everything that's done through SimonMed, or do all centers everywhere kind of utilize the technology? Didn't know if that's something that runs hand in hand with DTI as a whole.
Yeah, that's a great question, and we're trying to get it so we can do it automatically, so that every patient, just like every patient that comes to SimonMed gets an SWI, gets a neuroquant, gets DTI. We'd like it to be the case that every patient comes gets this, and we're working towards that. But there's some technical things, and then we're working with to try to get that to happen. Sure. Right now we have it. Right now we have it where the physician needs to specifically order it, and there's also a little bit of extra cost because to do all this, as you might imagine, is incredibly technical and it takes some time. And first of all, the normal databases is very valuable. I mean, to scan, the thousands of people that they did is a huge cost. So it's there's an upfront cost that Mindset charges to do this analysis. And so if you want that analysis, or if someone wants that analysis, they have to pay that upfront so we can do that. But that's a great question. And also another point, it has to be done on a scanner that is synchronized with the human phantom. So we can't do it on all scanners, but I think we have in Florida, California, Arizona, soon Texas, and actually in Illinois as well, and in New York. we're going to have this. And we already have it in Colorado. We have about maybe 10 or 15 scanners around the country that are synchronized with this. And we're going to be adding a lot more. So sometimes patients have to travel. We first started doing this in Las Vegas, and we are having people come in from all over the country. And then, we tried to make it easier on families and people to try to get some of our scanners doing. All right, so I think we got, so this is another thing is I think that's important to show either to juries or arbitrators or in presentations, is to include examples from the literature showing that these injuries or the area damage has been described by other people in the peer-reviewed medical imaging literature in head trauma. So here's some examples of injury to the splenium. So the last two cases we showed those little black dots, one on the left, one on the right. And so this is some literature showing how the splenium is commonly injured in head trauma. So I would show these cases and say that this is an area that's commonly injured in these articles and quotes, talking about how the splenium is, and the corpus callosum in general, it has a predilection for injury in head trauma. So here's another case of a matched defect. So this is how I would sort of present that, these matched defects in DTI and MRI. So here we have a hemorrhage, a black dot, hemorrhagic shearing in the right middle cerebral peduncle. And this is an area that's commonly injured in head trauma. And this is a SWI image showing that there. So then the Mindset DTI came back, and it showed the middle cerebral peduncle, the same area that hemorrhage was, had a almost 2 standard deviations below the mean in terms of the diffuser tensor imaging FA values as compared to the normal database. So this showed the DTI was matched exactly where that hemorrhage was. And sometimes it's helpful to show the anatomy. So this is where it is on an axial. This is just something I pulled off showing the anatomy. This is a 3-dimensional, so I would put a red star right here because that's where the injury is. So it allows to visualize exactly where that was. In this particular case, the splenium was also very low, but there was no corresponding abnormality on the imaging to the splenium, but it's still consistent with the history. I mean, there's likely a splenium injury based on the other imaging findings and based on that this is almost 2 standard deviations below. That's unusual. So that was the value in this case, how it added that area that was injured where we may not have said it before. And then this was the same case showing that injury. And then this is from the literature. So what they did was they took, in this particular article, they showed the red was where the trauma patients were different from the controls in TBI. And so you can see for whatever reason, the right seemed to be more injured, just like in our case. But all these red dots were on the right. And maybe it has to do with vector of force or who knows what. But this is what the peer review article found. So it's helpful to show it in this case because it adds support to your personal opinions. And then not just and then we showed a different article. This was showing the middle cerebral peduncle. This is the traumas and this is the controls. And the controls here had decreased FA values in that same region, the middle cerebral peduncles, relative to controls. This is the New England Journal of Medicine, so it's quite a reputable publication. And this we found in our patient the same findings that they found in their article, very high p-value.
Dr. Snyder, can I interrupt you for a few questions?
Sure.
Okay, the first is, I have a client that was 4 years old at the time of the crash. She was having issues with balance and falling often and was having frequent headaches. We managed to get an MRI. However, the results of the MRI did not show any damage. She recently turned 5, and because she continues to have headaches and continues to have minor problems with balance, would a DTI be beneficial?
Yes, I think that kind of case is kind of exactly what DTI is often used for, where there's clear symptoms following the trauma. It sounds like that is unexplained by imaging. One thing I would look at that original MRI and make sure it was a high quality MRI. Did they do SWI? Did they do thin section triplane imaging? Some of these MRIs, and I review some outside MRIs not infrequently, and some of them are just terrible. And then some of them, you hate to say it, but they're as good as ours, or I should say almost as good as ours. So there's a wide variation in the quality of imaging that's done. So that would probably be the first step. And then the second step would be 5 years old. they do have pediatrics in the Mindset DTI database. And so if the patient is able to sit still, which would be a question mark at 5 years old, but they might be able to, we could do this. And if we found positive findings, it might explain some of the symptoms that your patient's having.
Is there a list of symptoms that we need to look at that may be determinative of who in fact would be a candidate for this imaging technique?
Well, the brain has so many functions that it's just hard to say one symptom or another, but besides symptoms in general. I mean, if patient had a very minor head trauma and they had, just maybe some mild symptoms and they're fine, I guess there's a chance we could find something, but in my talking to these, various trauma neurologists and other people, it's, the worse symptoms that the patient has, the more likely the imaging is going to be positive, which intuitively, of course, makes sense. So, and then also patients without severe or pre-existing conditions, I think, if that might be an issue to weigh, if they have a lot of pre-existing conditions, and especially if they had a prior head trauma, which is not the focus of the case, then that might, depending on the specifics of it, it might sway you not to get the imaging.
And what is the usual cost of the scan, and does insurance or Medicare, Medicaid cover any of it?
So most insurances will not cover DTI. So there are some insurances that do. We've had some military people who have been able to be scanned. In some states, some insurance companies will cover it. We also have some cash pay patients. But the cost of this, we have multiple tiers of this where we have for attorneys, they can put these cases on a lien. Not the Mindset, because that's a fixed cost, so that has to be paid up front. But if we do these trauma protocols, we can put them on a lien. And then there's also an advanced trauma that we do, which is a cash pay. And that is, that's more thin section. We add spectroscopy, we add perfusion, we add, what else? Functional fMRI. So fMRI we do in the advanced cases. And so that's like that would be like a cash pay. But these are standard, we have like a standard other trauma cases that are a lot of times just put them on a lien. And I'm not sure what the cost is. I'm not really involved, in the billing part of it. It's different for each state. And I think SimonMed's prices, from what I hear, are fairly reasonable, or even in some cases, below what you might have to pay other places. But I'm not sure.
Yeah,
Thank you.
It's definitely one of those things from a cost standpoint. Just seeing it on a national level, it sounds bad to give a range, but they're truly, what it costs in, a center in Alabama, it does not cost in a center in, San Francisco. And so the prices range typically, I've seen them anywhere from $5,000 to, $13,000. And it kind of depends on the add-on, so to speak, that Dr. Snyder is hitting on, if it's got the Mindset component. But those are also where, alternative funding and those kind of things like HMR come into place, where we would fund, either, the DTI and the Mindset component, or advance some of the client to money. So I think that there's a host of options out there as far as being able to pay for it. Pricing, I think, is just dependent on where your client is.
Yeah, and so a lot of times, we'll get that question, should we order the advanced protocol or not? And a lot of it, I say, I hate to say it, but it's really not a medical decision. If it's, it really comes down to the attorneys, if the case is has a low insurance or low, you guys know the terms better than I do, then, may put it on the lien, where if it's some, there's a lot of liability, there was a pretty severe injury, then people will typically order the advanced imaging. So it just depends. Yeah. All right. Oh, sorry, go ahead.
No. I was saying I think we knocked out all the questions.
Okay, great. Okay, so so we'll kind of move a little faster here to the other slides. But this was I just want to show this case. This was one of the worst that I've seen. So this was the CT scan 2018, and this was a young person who was in a trauma, and the ventricles were diffusely bigger because of this contusion, because of the severe injury, and this is a poor prognostic sign, as we discussed before with those articles. So this was a very bad case. And then, so what did the DTI add in this case? Well, first of all, I guess we'll focus on the ventricles first. These ventricles are very big, and the volumetric shows these are in the 99th percentile. And this is a normal 6-year-old, and this was the case. So there's no question that, I mean, they were off the charts. This would probably 99.999 if it could. So these ventricles are big, and there's all this damage. So this was the particular patient. I'm showing this because this is probably the worst mindset DTI that I've ever seen. These are all the fiber tracts, those 48 regions. Hopefully you can see some of those, but all these tracts have functions. All these tracts are a valuable part for processing in the brain. And there's so many tracts here that are more than 4 standard deviations below the mean. So they're diffusely abnormal on the right and the left. I mean, this was a terrible case. This is the normal 3D, and this shows the like almost no fiber tracts here at all. I mean, there's this case is so bad. There's missing, and there's not even a single fiber tract for large parts of the corpus callosum in this brain. So it's I mean, of course, we knew the case was severely injured before, but I think this adds to show how bad it actually was. So this is the article Hugo was talking about before, which is it's a nice article because it's a review article. So this article did not do their own research. They reviewed hundreds of literature out there, and this is what the conclusion they came to after reviewing that. Peer-reviewed article in American Journal of Neuroradiology. This is a very prominent, probably one of the most prominent, if not the most prominent, journal of neuroimaging, and that was their conclusion of this article. So this is I cite this article a lot because I think it looks at everything and really shows the value of DTI. So we're almost to the end here. So putting it all together. So one thing that's I think is worth doing, as Hugo was saying, different pieces of the puzzle, and so to have like a kind of a summary slide showing all the findings. This is a case where to show all the findings with poor prognosis. So this is not all there are other findings besides this, but these are the findings with known poor prognosis in the head trauma literature. So you put them kind of all next to each other here. So it's kind of sums everything up. And DTI is not even in this, but this would be something to add too, where this is a lot of things we talked about today and also last time, which you can kind of show all the findings and the articles that support that patients that have these imaging findings in TBI have a poor prognosis. And those are the references. So any questions on DTI or anything else that we've covered in the past two lectures?
We do have one question, and that is, how far out from the date of accident can DTI be used effectively?
It can be used, the damage to DTI, generally speaking, is permanent, and I don't see it change a lot over time. So you can image someone 10 years after trauma, and you can still see the deficits. So there's no, DTI doesn't really have a time frame for imaging. If you image very close to the trauma, you can get some weird values where, because of the inflammation, it may cause the values to be a little different. And but overall, generally, in my experience, it's been pretty stable. I haven't seen them really improve. Occasionally, you'll see them worsen, and if they worsen, it could mean, well, it could mean a number of things. It could mean that they have some kind of process like chronic traumatic encephalopathy, where there's, from the inflammation from the trauma, you get this inflammatory response in the brain. That's one possibility. Another possibility, they have some other condition that is causing those fiber tracts to be, or they had another head trauma, or perhaps they're just getting worse from their head trauma. It's kind of tough to say.
Hugo, I've done a number of cases with you, so I hear you reference the literature early and often, and obviously we've heard a lot of it from Dr. Snyder as well. I'm curious how the literature, that's provided, and something like this plays into how you litigate a case and what's presented to somebody. Is that part of what you present to, defense counsel and say, hey, here's a positive DTI scan, here's the literature that supports it, to kind of squash anything that might come up in an objection or, opposition to that?
Oh, I wish it was so, but it's not. So yeah, there is a lot of literature that supports DTI, but just like Dr. Snyder put forth in a slide, there are articles out there and associations that are against the use of DTI, especially in litigation cases. So there was a big conference at Emory, I think 2 years ago, and they got a couple, radiologists got together and said, we don't think that DTI is ready for the courtroom. And that is what you're going to see in a lot of these articles, saying they're not ready for the courtroom. It's scientific research purposes, but they're not individualized yet. There's going to be literature on both sides. And the problem with scientific literature is that it's very unbiased sometimes. So almost every single piece of literature you read is going to say further study is necessary. So defense lawyers will always hone in on that and say, see, it's not definitive. It needs more. The problem they have is their articles are the same thing too. So at some point, it goes back into, the literature supports it, gets you past Dahlberg. There's some great literature out there that can open up some pathways for you to investigate other areas. But the way it has to work, to be really successful on this, is you have to be able to put it together with the other findings and with the real life effects. The DTI imaging is very pretty on the image slide, but if your client looks normal and he acts normal, a jury may not be inclined to agree that that means anything. They may buy the argument it's smoking, it's something else. You got to put it together with the real life experiences as well. So when Dr. Snyder gets up and says, the DTI says X, and the spectroscopy matches, and the SWI matches, and I would expect it to have these deficits. And then the wife gets up there and says, he can't do this and this. And then the neurologist says, you know what, he shouldn't be able to do X, Y, Z. And then the physiatrist at the long-term care facility says, listen, I've seen him make these mistakes. Now you put everything together. And that's when you really have a powerful presentation.
Got it.
Yeah, Kyle, and I think that's a good point. I tend to err on the side of using too much literature. And the reason is because a lot of times, if you have two people arguing and someone says, it's my opinion this, and someone says it's their opinion that, so what's the, what's the tiebreaker? How does someone decide who is right? So I always try to use a lot of literature. I put literature actually in my clinical reports when I dictate. I put it in the clinical reports to give backup to the findings, to say that this is not my opinion that someone with a subarachnoid hemorrhage is more likely to have a poor outcome. It's this article, and I'm just relaying the information from that article as it relates to this case. That's what you expect any physician to do, to take the medical literature and you practice based off the medical literature. So I think having a lot of citations, for example, showing these types of showing that it just adds more background to your opinion. So you already know that this. I know this is hemorrhagic diffuse axonal injury in the right peduncle, but adding all this stuff in will educate someone who may not be a neuroradiologist or may not understand that, and maybe think that my opinion is not valid. So when you add all this layer on there, showing all this stuff, showing the anatomy, showing what it is, and then especially if there's some clinical support where there's symptoms from it and all that, then you really have a airtight case and good science, importantly, good science.
And look, Dr. Snyder is quite modest, but the reality is a lot of the literature, he's the one doing the research and publishing most of these articles. So he's able to sit there and say, listen, I actually spearheaded it. And let me tell you about this article that I'm working on, and this is what I'm doing. So that's why it kind of pays off to work with somebody like him.
Well, I wonder, people who might be getting a DTI somewhere, I hear often, I've got a report, I'd like an overread, or, I want, you know, how that transition plays into somebody like Dr. Snyder and what's needed to get that accomplished, you know, if you don't, you know, obviously have, you know, him in your backyard, you know.
Well, I'm happy, Hugo, by the way, that was very, very kind of you, but we have more in the works than we have to show right now. I mean, I'll show an article we did, but yeah, we're working on some really exciting stuff, but there's other people have done a lot more than we have yet. But yeah, I mean, as far as outside imaging, I mean, I review outside imaging, you know, all the time, and you know, happy to do it and do, you know, addendums or additional reports, or you know, sometimes you know, you disagree or agree, you know, with what the clinical report said. Sometimes people just want to have a, you know, like a trust factor to some. If I work with people a lot, and they say, you know, can you look at this and you know, do you agree? And I'll look at it and say, yeah, I was read great, agree with it, and then you know, that's it. Or you know, they missed something or whatever, and it's, you know, one thing I think we talked about before, I see missed a lot is the soft tissue contusions on CT, very commonly missed by radiologists. And there's other things that you kind of learn what to look for, things that are more likely to be missed, and you know, look for those. Whiplash injury is something that is the findings are, it's kind of complicated. The literature is complex on whiplash findings, but I think that, you know, a lot of maybe radiologists are not as up to date on some of the subtleties of it. So it just depends what it is.
Gotcha.
Whenever we do these cases, you have to be aware that if you bring in Dr. Snyder or a foreign neuroradiologist, you're going to be subject to attack. They had to go to Vegas and bring a guy. They couldn't bring a guy from, you know, whatever research center we have here, whatever hospital we have here. So you're going to have somebody who's well published, and you're going to have to explain it to a jury why you bring in Dr. Snyder from Las Vegas to testify in, I don't know, Gulfport, Mississippi.
Right.
And I mean, luckily for us, Dr. Snyder does a lot of work with the Nevada Boxing Commission. So we can always talk about boxing and how, you know, every boxer in Las Vegas got to go under his scanner, and kind of gives him a little bit of credibility boost. Well, if boxing uses him, he must be good.
Right.
Yeah, MMA fights in Las Vegas. Yeah, we do a pre-screening for all those, so it's kind of fun. We're trying to maybe do a research project on that actually with some of the guys there, so it's pretty interesting.
Yeah.
So do we have any time left, or?
I don't.
I think we're almost out of time, but I think you only have a slide or two left if you want to wrap it up with those.
Okay, well, yeah, so we won't get in, since we're out of time here, I won't get into this, but this was a recent article we published, speaking of publication, and we have a lot more coming after this, looking at subgroups in this, and this is on 250 patients, and we actually have about 800 patients that we have now that we're ready to look at all these different stuff. And this is the largest study that has been published on mild traumatic brain injury patients in litigation. So all these patients were in litigation. And so we looked at all this stuff, and I think you'll find a lot of the things we talked about in this these last two talks are sort of incorporated into this article in different ways. With all of the citations are in there, you know, talking about it. So just something that you might find interesting to read. And anyway, we found that the point of this article was we gave a patient normal or abnormal MRI status. And we excluded any patient in the study was excluded if they had contusions, if they had hemorrhages, if they had bleeds in their brain. So all that was excluded. So what we're left with was the volumetrics, DTI, fMRI, and then white matter findings. So we tried to look at things that were not as well described in some areas in head trauma. And we found that with if they had an abnormal MRI based on those criteria, that they were significantly likely to have a longer outcome. So all the stuff we're talking about, you know, we showed in this research that it is valid, and other studies have shown it too. But I think that there'll be a lot more kind of exciting things coming out. So anyway, thanks so much. Oh, this was thanks Don for this reference from part 1 on whiplash. I did not include this article, but it was a pretty nice article that was sent over to us. So I wanted to make sure that people got that if they need it. And speaking of Vegas, this was our contortionist here who was in the magnet. And this was a cool MRI image we got of her. This is her head, and she's arched all the way back, and this is her butt there. So she's doing a complete arch. It was kind of a cool image. So I just wanted to show that. So any questions? And thanks to all the moderators and thanks to everyone. This was a lot of fun, great questions, and hopefully we can do it again sometime.
I wonder if everybody's head went like this on that last that last image.
Mine did.
Well, this
yeah.
was absolutely fantastic. I mean, I'm blown away by how much more that we learned today. You guys did a fantastic job. Thank you so much for this. And I wanted to let everyone know that I am going to send you a copy of Dr. Snyder's slides, because it really is incredible to go back and just kind of look at this. And you might think of something else later that you want to ask him. So please definitely reach out to Dr. Snyder, Hugo, Kyle, or Haley if you have any other questions. And Dr. Snyder, I'm going to show this real quick. Is it okay to close out of this?
Oh yeah, Ginger, by the way, I wanted to make one little, I saw a typo in here. I wanted to make one before you send it, if you don't mind. Thanks.
Okay, perfect. I'll hold off until I hear back from you on that one. And I've got this right here to show everybody that I'm also going to send everyone's contact information who spoke today. So again, you can reach out to Haley, Hugo, Dr. Snyder, Kyle, Keith, who's over at Global Litigation Consultants. Thank you so much for being such a great sponsor of ours. And then also to Paul Luttrell with Strategic Relationships. And that means now I have a quick announcement to make. And our winner of the $100 giveaway for the strategic gift certificate to Fleming Steakhouse is, I'm going to show that to you guys right now. Congratulations to Carolina.